course, yes, yes, please.
Yes. All right, so the concept of passage of meconium is one in premature babies that is one that is sometimes very confusing to many people, and it is a concept that many people have that meconium needs to be passed very shortly after birth, and that babies should be stooling just about every single day if they're preterm. Well, the studies that have been done looking at this show that meconium passage is delayed in many of our preterm babies with birth weights less than 1,500 grams, and sometimes this may be delayed up to 10 days in infants with birth weights less than 1,250 grams. It's important to remember that if you are feeding the baby, then you will probably have meconium passage earlier, but if you are not feeding the baby, you will probably not stimulate the passage of meconium. It is a concept also that suppositories or enemas be used in preterm babies, and many units use these routinely, but this is not based on any really good evidence. So I would actually recommend against the routine use of suppositories and enemas in preterm babies. So as far as the take-home messages, I think that I want to point to here that motility is limiting, but all of the functions that relate to motility are stimulated by enteral feedings, and that we should try to use the gastrointestinal tract in preterm babies whenever possible. And I'll talk more about that in the next lecture.
Okay, okay.
Any questions?
I think we will wait for the questions until the end of the second lecture also.
Okay, very good. Is the audio better?
Yeah, it's better.
It is better. Okay, very good. So I will go to the next lecture.
Yes, please.
Okay?
Okay, yeah, please.
Okay. Okay, can you see the slide okay?
Yes, we can see it.
This is the first slide, the title slide?
Yes, we can see it.
Okay, and you can hear me okay?
Yeah, and we can hear you clearly.
Excellent. Okay, so I will start. Is that all right?
Yeah, please start.
Okay, so here we see appropriate for gestational age, a 27-week premature baby. And the question is, how do we nourish this baby? I would like to just mention that historically, when I first started in neonatology, which was in the mid-1970s, a baby like this, 27-week premature, would very likely not survive. We would put these babies in the corner of the neonatal intensive care unit. We would keep them warm. They would try to breathe, and they would eventually die. But now we have most of these babies surviving, but their survival is still not optimal. And one of the problems for their non-optimal survival is related to our lack of being able to nourish these babies appropriately. But over the last 20 or so years, we're getting a much better database to be able to rely on to feed these babies more appropriately. And that's the purpose of this lecture. So I'd like to start with the agenda for the next 50, 60 minutes. I want to talk about the nutritional emergency of extremely low birth weight preterm infants, then talk about nutritional strategies, both parenteral and enteral nutrition, then talk about the transition period in the neonatal intensive care unit, and post-discharge nutrition. So let's start with the goals of early nutrition, both enteral and parenteral. We want to prevent short and long-term morbidities associated with malnutrition, We want to be able to avoid nutrient toxicity. And even though this is a very high goal, we want to attain growth comparable to that in utero. For the most part, we are not doing quite as well as what we would like to be able to do. Here are the intrauterine growth curves. This is the 50th percentile. This is the 10th percentile of what we would consider to be a reference fetus. But these are curves of preterm babies at various gestational ages. And here we see the very low birth weight preterm infant, 24, 25 weeks, lagging way behind what that baby would be looking like if that baby would be still in the uterus. Now, this was published in 1999, and I think we have done some, we have made some improvements, but we are still not quite there with our overall nutrition of these preterm infants. So what are some of the common practices, and what are some of the problems that we have in nutrition of these babies? Well, here are some common practices in terms of parenteral nutrition. Very frequently, amino acids are started in the first week of life, and they are advanced slowly in increments. Lipid infusions are started in the first week of life and are also slowly advanced. And these are frequently delayed or interrupted because of some concepts that we have that are not necessarily based on very good evidence. I'm going to provide an argument for you that we should be starting these immediately right after birth, and that we should not delay them or stop them for most of the reasons that they are being delayed or stopped. What about enteral feedings? We use many excuses to delay or withhold enteral feedings. And this picture is a baby with a distended abdomen, and this baby has developed necrotizing enterocolitis. And we are very afraid of babies developing necrotizing enterocolitis, and we have this concept that feeding is a major reason for babies developing necrotizing enterocolitis. And so because of this, we have these concepts or excuses to not feed preterm babies. These concepts include low APGAR scores, umbilical artery catheters, apnea and bradycardia, mechanical ventilation, CPAP, the use of vasoactive drugs. None of these reasons that or excuses that people have to stop these feedings are based on very good evidence. We also have this concept that TPN is available and babies grow just fine on TPN. Well, that is not the case. You don't get gut growth with TPN. You have to provide some food into the gastrointestinal tract.
We cannot hear you, please, just for a while. Professor Joe. Hello?
That these babies attain,
okay,
but with this increase in calories.
Sorry, excuse me, please. The last slide, with the end of the last slide and this slide, we didn't hear it.
Okay.
Okay.
Can you hear me now?
Yeah, thank you.
Okay. So these are all excuses that are not based on evidence. Growth with TPN. You have to put food into the gastrointestinal tract for the gastrointestinal tract to grow. This is data from 50 different British neonatal intensive care units, published in 2008. There have been some changes since then, but overall, this is a concept that we still have in many neonatal intensive care units, that we advance our enteral feeding slowly, and we don't get to full enteral feedings for sometimes many, many days in our preterm babies, and this leads to a cumulative deficit. And this is not only for enteral feedings, but also parenteral nutrition, that we do not provide adequate enteral or parenteral nutrition for many days, and this leads to a deficit of calories. And here we have protein also increasing slowly, which leads to a protein deficit. Now, it's very important to remember that these very low birth weight babies, if you look at their body composition, this is work done by Eckhart Ziegler, if we look at their body composition and we look at their lipid stores, the amount of lipid in these premature babies is minimal. It is only about between 0.1 to 1.5% body fat. And with such low lipid stores, we have a major problem in terms of their energy. We don't have much, these babies do not have much energy. So we have to provide energy for these babies shortly after birth. If we don't provide this energy, they will become catabolic very rapidly and begin to use their own protein stores for energy production. Here we have a picture of a brain at 25 weeks gestation and at term. And you can see the tremendous amount of development that occurs during this last trimester of pregnancy. And without good nutrition, this development will not occur normally. This is a study that was done at Brown University by Dr. Betty Bohr and her colleagues. And what they evaluated here was the first week protein and energy intake and neurodevelopmental outcome at 18 months. So this is only looking at the first week of amino acid intake or energy intake. And at 18 months, they did a MDI, Mental Development Index. And what they found was that for every 1 gram per kilo per day of amino acid difference in that first week, there was an 8.2 MDI point difference. So IQ at 18 months is very different depending on small increments of amino acid intake. How about energy? For every 10 calories per kilo, there's a 4.6 increment in MDI. So the first week after birth represents an emergency in these babies, and we need to be providing adequate amino acids and energy to these babies shortly after birth. This is another study that looks at neurodevelopmental impairment and neurodevelopmental outcome. And I want to focus just on these panels down here. These are weight quartiles during hospitalization of preterm babies. So those babies who gained the highest amount of weight had the least amount of cerebral palsy. And same thing with neurodevelopmental outcome. Those babies who gained 21.2 grams compared to 12 grams, those babies had the lowest neurodevelopmental impairment. So what about energy requirements in these extremely very low birth weight babies? Well, if they are being fed enterally only through the gastrointestinal tract, they require approximately 120 calories per kilo per day for growth. If they are on TPN, this is total parenteral nutrition, Studies have shown you can get positive nitrogen balance with 60 calories per kilo per day, with about 2.5 grams per kilo per day of protein. Okay, so you are giving some calories with that protein, and that protein is not utilized for energy production if you are giving enough calories. But this is just to attain positive nitrogen balance. If you want to get the babies to actually grow and to have weight gain on TPN, you need to give these babies approximately 80 calories per kilo per day. Here is the preterm nutrition actual recommendation for protein. For the extremely low birth weight infants, if you look at what they would be getting in utero and compare the amount of protein that they are getting in utero to what we should be giving them once they are born preterm, we should be giving these babies about 3.6 to 4 grams per 100 kilocalories, according to the European Society of Pediatric Gastroenterology and Nutrition. In the bigger preterm babies, they don't need quite as much as these very low birth weight babies. So you see about 3 to 3.6 grams per 100 kilocalories. This is work that was done by Dr. Patty Thureen in 2003, and a very famous study that was published in Pediatric Research, where they looked at protein balance and provided 1 gram per kilo per day of amino acids versus 3 grams per kilo per day of amino acids, and they used 2 different methods to evaluate protein balance, nitrogen balance method and isotope method. And with 1 gram per kilo per day, you can see that there was not very good protein balance, but with 3 grams per kilo per day, these babies were getting positive protein balance. They also looked at the glucose levels in the bloodstream of these babies. These are the babies who are getting 1 gram per kilo per day and 3 grams per kilo per day. And the glucose concentration in the blood was about the same. But the insulin concentrations in the blood was considerably higher in the high amino acid group. So what does this mean? Well, this means that the amino acids stimulate insulin production, and insulin is a growth hormone, as you know. We also are able to control hyperglycemia and hyperkalemia better in some of these very low birth weight infants, where hyperglycemia and hyperkalemia, and that can be prevented if you do not delay the total parenteral nutrition with amino acids. Many years ago, in the early 1980s, I was at a conference and I heard the speaker, very famous neonatologist, say that intravenous lipids are poison. And birth, we can start these babies on 3 grams per kilo per day. Now, when I give lectures to audiences across various parts of the U.S. and other places in the world, I ask people if they start their babies on 3 grams per kilo per day of amino acid right after birth, and most places do not start their premature babies on amino acids or lipids right after birth. So this is a potential problem. This is a study that was published in France by Dr. Alexandre Lapillon, and in French neonatal intensive care units, the survey showed that in 80 to 90% of French neonatal intensive care units, sepsis, hemodynamic failure, thrombocytopenia, disseminated intravascular coagulation, and hyperbilirubinemia were considered to be relative or absolute contraindications for giving lipids. But guess what? None of these have been shown by studies to be contraindications for giving lipids to preterm babies. We have this problem that we sometimes see in preterm babies that is called essential fatty acid deficiency. And this is a preterm baby who did not receive lipids for the first 2 weeks after birth. This baby had some respiratory distress, had some hyperbilirubinemia, and the neonatologists, because of the hyperbilirubinemia, did not start this baby on intravenous lipids because they were afraid that the intravenous lipids would displace bilirubin from the albumin molecule and cause brain damage in this baby. Well, that whole concept has been disproven. And we do know that essential fatty acid deficiency can be very harmful for these babies. So what are the essential fatty acids? Well, first of all, an essential nutrient is one that cannot be produced by the body, but is needed by the body for normal functions. There are 2 essential fatty acids. One is linoleic acid, and that has 18 carbons with 2 double bonds, and the first double bond at the 6th position, and linolenic acid, which is also 18 carbons, 3 double bonds with the first double bond at the 3 position. These are the essential fatty acids. And if we don't give these to our premature babies, they will develop essential fatty acid deficiency. A study that was done in the early 1990s at the University of Wisconsin evaluated how long it would take to develop essential fatty acid deficiency in premature babies. And what I would like you to do is to just focus on this first column here. What they did was they looked at babies who were receiving no linoleic or linolenic acid in the first 7 days after birth. So here you see 0, 0, 0. Then they looked at something called a triene to tetraene ratio. A triene to tetraene ratio evaluates the metabolism of these essential versus non-essential fatty acids. If you have a triene to tetraene ratio, which is greater than 0.2, this signifies that the baby has essential fatty acid deficiency. So after 7 days, 80% of the preterm babies who were not receiving linoleic acid or linolenic acid developed essential fatty acid deficiency. Only 7 days, 1 week, is what it takes with no essential lipids to develop essential fatty acid deficiency. Another important finding in this study was that you could prevent essential fatty acid deficiency by only providing approximately 1 gram per kilo per day of lipid, intralipid, to these babies. Now, remember before I said that a preterm baby requires approximately 80 calories per kilo per day for growth if that baby is only on parenteral nutrition. Now let's do a calculation and assume that we have a baby who weighs 1 kilogram. Let's say we are giving this baby 8 milligrams per kilo per minute of glucose. That provides 39 calories. And if we are giving 3 grams per kilo per day of amino acid, that provides 12 calories. So we still need 30 calories to get 80 total calories. And if you do the calculation, that comes out to be almost 3 grams per kilo per day. So if we want to attain growth in a preterm baby who is receiving only TPN, we have to provide approximately 3 grams per kilo per day of lipids, of intravenous lipids. Here is one study from the group in Amsterdam, Hans van Goudever's group. I'm not going to get into all of the details, but this is a study that supports using early lipids. It supports the safety and efficacy of using early lipids in preterm babies. So in our unit, in the neonatal intensive care unit at the University of Florida, what we have done is we have developed guidelines, and as far as intravenous lipids, we give 3 grams per kilo per day, and we infuse it over 24 hours, starting shortly after birth, with a maximum of about 3.5 grams per kilo per day. We try to provide no more than 50% of the total parenteral calories per day from lipids. And to avoid this, we titrate the intravenous lipids down as the parenteral nutrition volume decreases and the enteral nutrition volume increases. We do not routinely check triglycerides. If the blood samples become lipemic, we only check the triglycerides only if the samples become lipemic. And once we do get a triglyceride level over 400 milligrams per deciliter, that's when we will decrease the lipid infusion. If the IV access is limited, we may need to window lipids around medication administration or infuse lipids over a duration less than 24 hours. And we will discontinue the lipids when the IV nutrition volume is 40 milliliters per kilogram per day, or when the enteral feeds reach 80 milliliters per kilo per day, whichever comes first. So these are the guidelines that we have developed for our unit. Now, the question then becomes, what about the quality of lipids? Here is a metabolic scheme that looks at omega-6 lipids and omega-3 lipids. The omega-6 lipids, the parent compound is linoleic acid, and with the omega-3 series, we have linolenic acid. In the metabolic scheme, these parent fatty acids get desaturated and elongated. The omega growth and development. You have to have a combination of these. You cannot just provide one or the other. And one of the problems many premature babies have is that their elongation and desaturation mechanisms are still immature, and it takes some time for these to develop. So to be able to actually synthesize these very long chain polyunsaturated this baby can become DHA deficient. And so we have a problem that even if the mothers are receiving high fish oil in their diets, if we are not feeding the babies with their breast milk, you can have mothers that are eating a lot of fish, but if you are not really feeding these babies their mother's milk, then what happens is that they can still become deficient in some of these essential fatty acids. So here we have DHA and some other fatty acids, and what their accretion rate is in utero. And I want you to focus here on the bottom on the DHA. And in utero, the fetus is getting approximately 43 milligrams per kilo per day of DHA. Here we have that level, the in utero accretion. And here is a study done again by Dr. Alexander Lapillon showing babies who are receiving enteral as well as parenteral nutrition. These are preterm babies, and their milligrams per kilo per day of DHA that they are actually getting in their first 4 weeks of life. So here we see this is very different than what they would be getting in utero. So this baby would have a DHA deficit of 661 milligrams per kilo by 28 days after birth. Here is some work that was done by a colleague by the name of Cami Martin at Harvard University, and she looked at postnatal week, and this is mean DHA concentration in the blood. Here we see babies with no chronic lung disease having higher mean DHA concentrations than babies with chronic lung disease. So we see this association that babies with chronic lung disease have lower mean DHA levels than those with no chronic lung disease. So what kind of lipid infusions do we have for our premature babies? In the U.S., we have had primarily intralipid, and just recently SMOF has been introduced in the U.S., but it is not yet routinely used in preterm babies, but it has been introduced, and more neonatal units are beginning to use SMOF lipid. What is SMOF lipid? Well, SMOF, S stands for soybean, M stands for medium chain lipids, O stands for olive oil or oleic acid, and F stands for fish oil. And so this is the derivative of this SMOF lipid, and SMOF has high DHA concentrations, but also has arachidonic acid. And so this appears to be, at least from a theoretical perspective, a better lipid formulation than the intralipid that we have used for the last almost 4 decades in the U.S. and other countries as well. This is one paper, one of now several, that suggests that the use of SMOF lipids might actually be advantageous and certainly safe in premature babies. Okay, so let's get to some questions. And I'd like to ask you about this particular baby. This particular baby is appropriate for gestational age. Had APGARs of 3 and 5. The baby has UA and UV catheters in place. And the baby is getting mechanical ventilation and prophylactic indomethacin. So the questions I have are, number 1, can we feed this baby using the gastrointestinal tract? What are the consequences of not feeding this baby by the gastrointestinal tract? And how do we go about doing this? Okay, so here we have the consequences of TPN and no enteral nutrition. Again, I want to reiterate that no food in the gastrointestinal tract is bad. You have increased mucosal atrophy. You have a lack of trophic hormones. You have a greater systemic inflammatory response, greater potential for cholestasis, increased adhesion molecules and PMN attraction, so more inflammation in the gastrointestinal tract if you don't have food in the gastrointestinal tract, and you have TPN-associated sepsis. In fact, no food in the gastrointestinal tract will cause increased permeability and more translocation of bacteria through the gastrointestinal tract. Over 60 years ago, this lady, Dr. Elsie Widdowson, in the UK, showed that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If that piglet is not fed enterally, that intestinal this weight gain does not occur. And there are numerous studies since Dr. Widowson's studies that have shown that the gut does not grow unless you put food into it. This is another study done in animals at Baylor University. And what they did in this study was that they looked at DNA in the gastrointestinal tissue, protein, and the wet weight of intestinal tissue, and they used a TPN formulation that they either gave enterally or parenterally in different quantities. So here, at the very beginning, we have an enteral intake, which is 0, and here at the top, we have an enteral intake, which is 100%. And you can see that with no enteral intake, or very small amounts of enteral intake, you have very poor gut growth. So you have to have food in the gastrointestinal tract for mucosal growth to occur. And this is the same slide that I showed in the previous lecture, that minimal enteral nutrition, by putting small amounts of food in the gastrointestinal tract, you can actually have a pharmacologic effect where you have better gut growth and you have less complications, such as you can actually have less complications such as necrotizing enterocolitis with minimal enteral nutrition. So how do we define minimal enteral nutrition? Usually this is considered to be less than 20 milliliters per kilo per day of enteral feeding, and this is feeding that will feed the gastrointestinal tract but not be adequate for nutrition of the entire baby. So this has to be supplemented with parenteral nutrition. Again, you have this surge in gastrointestinal hormones if you provide enteral feeding, but this does not happen if you give parenteral feeding. Here we have a liver in a piglet with enteral feeding after 7 days and with TPN after 7 days on the right. You can see these livers look very different. In the piglet that gets only parenteral nutrition on the right, you have H&E staining that shows a lot of fat deposition, and you see these ballooning. TPN get increased infections through their lines, through their TPN lines. But many of these infections come through the gastrointestinal tract. Again, you have a very large surface area, and if this is broken down, if you have breakdown of the tight junctions, as we see in this cartoon, you have translocation of bacteria. For 2 or 3 weeks. And that's what made this particular study that I'm showing you on this slide possible. What was done in this study was that they looked at the permeability of the gastrointestinal tract of preterm babies using what is called the lactulose to mannitol ratio. These are two sugars that should not be absorbed through the gastrointestinal tract. Lactulose, if it is absorbed and gets into the bloodstream, if you have high quantities of lactulose to mannitol, you have more permeability or a leaky gastrointestinal tract. And what they found was that in babies who were getting small amount of enteral feeding, this is a group that was getting GI primed starting on day 4 after birth, compared to TPN only to day 15. This is TPN only to day 15. There was a greater permeability of the gastrointestinal tract compared to those babies who were getting some food in their gastrointestinal tract. And this is very likely to be one of the reasons why those babies who are getting prolonged parenteral nutrition have a higher incidence of sepsis and infections because of translocation of bacteria through their gastrointestinal tract. More recent studies, and this is one that was published in July of 2015. The title of the study is Late Enteral Feedings Are Associated with Intestinal Inflammation and Adverse Neonatal Outcomes. And in this study, what was done was that they compared babies who were being fed enterally prior to 4 days versus babies who were being fed after 4 days. And here we see some of the neonatal morbidities by the group. NEC, ROP, chronic lung disease, PVL, IVH, and all the comorbidities together. In the early feeding group, you can see these numbers are consistently lower than the late feeding group. And this is after correction for confounding factors. You see that the early feeding group has much lower morbidities than the late feeding group. Okay, so what about some of the things that we do in neonatal intensive care? Let me ask you these questions here. Do you stop feeding if you give the baby indomethacin for ductus arteriosus? What about indomethacin for IVH prophylaxis? What about blood transfusions? Well, let's talk about these in a little bit more detail. This is a study that was done and published just a couple of years ago. This is a multi-center study that was done by Ron Kleiman from University of California, San Francisco, and they looked at enteral feeding during indomethacin and ibuprofen treatment of a patent ductus arteriosus. What they found in this study was that feeding when giving indomethacin or ibuprofen did not increase the incidence of necrotizing enterocolitis. But those babies who were not being fed grew slower, and they did not receive the same amount of feeding volume. And it took longer to get those babies to adequate feedings if they were put NPO when they were also getting indomethacin for ibuprofen or ibuprofen while they were being treated for a patent ductus arteriosus. Okay, so I'd like to go through sort of a summary of guidelines that I would recommend. These are very similar to the guidelines that we have here that are evidence-based guidelines. So what we do is we start with rate, if babies are born prematurely, we start with the minimal enteral nutrition phase, and we initiate at a rate of less than or equal to 20 milliliters per kilo per day. There are some studies that suggest that you can even go up to higher levels, 35 or 40 milliliters per kilo per day without increasing necrotizing enterocolitis. We have taken a conservative approach with only using 20 milliliters per kilo per day and increasing at a rate of 20 milliliters per kilo per day. If you are extremely concerned, you can keep minimal enteral nutrition that is less than 20 milliliters per kilo per day for up to 3 to 5 days without advancing, but then they consider slowly advancing over 5 days. Then we have the advancing phase where we advance by up to 20 milliliters per kilo per day and is tolerated. And as the feeds advance, we decrease the parenteral nutrition and intralipids accordingly. And this is just the regimen that we use. We have actually started to change this where we decrease the parenteral nutrition at a higher quantity than 60 milliliters per kilo per day. We are now saving that to about 80 to 100 milliliters per kilo per day. We fortify breast milk with human milk fortifier. And when parenteral nutrition is discontinued, we fortify the breast milk to 22 calories per kilogram by adding 1 packet of human milk fortifier to 50 milliliters of breast milk. And when enteral feeds reach at least 140 milliliters per kilo per day, we fortify it to 24 calories per ounce, and we add 1 packet of human milk fortifier to 25 milliliters of breast milk. So again, I want to just go back to this feeding controversy with enteral feeds and indomethacin. This has been a common problem in many neonatal intensive care units that enteral feeds are stopped when indomethacin is given. There is no evidence that the administration of indomethacin warrants discontinuation of enteral feeds in the preterm infant. So we recommended continuing feeding during indomethacin administration if there is no other contraindication to doing so. However, we have to remember that there are some reports that describe a higher incidence of spontaneous intestinal perforation in infants receiving concurrent indomethacin and hydrocortisone or dexamethasone. So this is a very important point to remember. Do not give indomethacin together with glucocorticoids, because that results in a higher incidence of spontaneous intestinal perforations. What about bolus versus continuous feeding? There's no evidence that continuous feeding is superior to bolus feeding or vice versa. Certain patients may benefit from continuous administration of feeding, such as those with severe feeding intolerance or severe gastroesophageal reflux disease. Bolus administration is preferred because it's thought to be more physiologic and stimulates gastrointestinal motility and secretion of intestinal hormones and enzymes. And these babies do have to eventually get to bolus feedings anyway. So if they tolerate the bolus feedings well, it is worthwhile just sticking with the bolus feedings to begin with and to continue with those. What about transpyloric feedings? A review of trials found that babies receiving transpyloric tube feedings had more adverse effects without evidence of increased benefit over gastric tube feedings. And I want to refer you to this study here, Watson and McGuire. Enteral vitamin mineral supplementation. We initiate pediatric multivitamins with iron when patients are there is a potential problem when you start adding a lot of material to either formulas or mother's milk. The American Academy of Pediatrics, as well as the European agencies, recommend to limit the osmolality of the feeding to around 400 milliosmoles per kilo. But once you start adding is always recommended whenever possible. There is good evidence for lower neck, higher IQ, decreased sepsis, better tolerance, and the American Academy of Pediatrics has recommended exclusive breastfeeding in very low birth weight infants, and most of our neonatal ICUs have taken that very seriously, and we are using very little formula in our babies that are less than 32 weeks gestation in our neonatal ICU. So here's a question. Do you have feeding guidelines in your neonatal intensive care unit? If you don't, you should have feeding guidelines in your neonatal intensive care unit. Studies have shown that you can actually decrease many of the morbidities seen in neonatal intensive care related to feedings if you have feeding guidelines. I want to refer you to a couple of publications that we published in Neo Reviews a few years ago on feeding guidelines in neonatal intensive care. These are now actually a little bit old. We have made some changes in our own feeding guidelines, and so here's a timeline in our neonatal intensive care unit, some of the things that we have done. We've developed a NICU nutrition team that consists of neonatologists, gastroenterologists, pediatric surgeons, etc. And we've revised these feeding guidelines. We've been doing this over and over. And now we are beginning to actually do quality improvement initiatives to see what these feeding guideline changes have done. So, for example, this is one of our studies looking at feeding guidelines and the results in terms of days to 120 milliliters per kilo per day in 2014 versus 2015 and 2016. Duration of PN, we've been able to improve. Duration of central lines, venous central lines, we've been able to improve. And here we see no change in terms of necrotizing enterocolitis or other problems seen in neonatal intensive care. This appears to be an outlier. We don't know what happened, but this probably has absolutely nothing to do with nutrition, this blip in intraventricular hemorrhage. But again, this is very important. If you are doing, if you have guidelines in your neonatal intensive care unit, you should be doing quality improvement initiatives and monitoring these as you go on. Now, what about after discharge? There are post-discharge formulas available that contain more protein, calcium, phosphorus, zinc, and added vitamins and trace elements. And we still have some problems in deciding which babies should be getting these nutrient-enriched formulas after discharge. The goal of using a nutrient-enriched formula is to increase proportional growth, bone deposition, and lean body mass. So I'd like to refer you to this study that was, these are guidelines from the ESPGHAN Committee on Nutrition, and most of these still hold true today, that appropriate for corrected age infants at discharge should be breastfed. When formula fed, such infants should be given standard infant formula. Subnormal weight for corrected age infants have an increased risk of long-term growth failure. If fed human milk, they should be supplemented to increase nutrient intake. If fed formula, they should be getting a post-discharge formula. The post-discharge formula should be fed until a corrected age of 40 weeks, but possibly in some very high-risk babies up till 52 weeks. The untoward effects of high protein and mineral formula in the first year must be considered. Again, we still are learning more about these effects, and perhaps there are some epigenetic effects or effects on obesity and catch-up growth that could be a potential problem, but we are just beginning to learn about those. Early nutritional support reduces growth failure and reduces the need for high nutrient supplies after discharge. So this is a questionnaire that my colleague Richard Chandler uses, and I'd like to show you this. If a baby has and this is a questionnaire, a pre-discharge screen, if a baby has an oral intake of greater than 100 milliliters per kilo per day, if the answer to this question is yes, you can consider using a term diet. If there is adequate weight gain, you can consider using a term diet. If the nutritional indices are appropriate, by nutritional indices, I mean blood, urea, and nitrogen, alkaline phosphatase, and phosphorus, then you can use a term diet. And if the baby does not have BPD, you should consider a term diet. If all of these responses to the discharge screen are yes, you can send the baby home breastfeeding and on breast milk and no supplementation. If any of the responses to discharge screen are no, one can use a combination of breastfeeding, breast milk, and supplemental formula mixed with human milk, supplemental formula with separate feedings, supplemental formula which is concentrated to booster levels, human milk fortifiers, or post-discharge formula up to around, sometimes up to 6 months. How do you monitor? Look at oral feeding ability, growth charts, biochemical measures. These are probably some of the best that we have, most clinically available, and maintain appropriate percentiles. And in some babies, we may want to continue for 6 months to 1 year. So I'd like to stop here with some take-home messages. Early nutrition, immediately after birth in preterm babies, is important to prevent significant morbidity. Many of the dogmas that have prevented rapid incorporation of early nutrition have been either disproved, not based on fact, or weak. Guidelines for early, transitional, and post-discharge nutrition have been shown to be beneficial, and these are highly recommended to be used in your neonatal intensive care units and in the babies that are discharged from your neonatal intensive care units. Thank you for your attention.
Okay. Thank you very much, Professor Neu. We were enjoying your lecture. It's actually very fruitful for us, full of information. Can we take a few questions, please?
Yes.
Okay.
Dr. Neu, that's Hisham Awad speaking. We are very glad to hear you and to see you and to benefit from your knowledge. I just want to ask a question. If you have a previous premature baby who is taking enough calories and he's not thriving, in spite of having a normal hemoglobin, do you give him supplementation with additional salt? And when do you do so? Another question you didn't answer about the issue of transfusion, feeding with the transfusion. I need to hear about it. Thank you.
Professor Neu, did you hear the question? Professor Neu, do you hear our questions?
Or is the baby on formula? Can you hear me?
Sorry, did you hear the questions?
So I need to have a little bit more information. From what I heard about the question was that you have a preterm baby who is being fed full enteral feedings, but is not thriving, is not growing.
Yes.
I need more information about that baby. What is the gestational age? What is the baby receiving? Is the baby receiving breast milk?
Yes.
Is the baby receiving formula? Or if the baby is receiving formula, what kind of formula is the baby receiving?
No, he's receiving breast milk. He was a previous 28 weekers, and he's receiving breast milk at 200 cc per kilo per day. he is having an adequate hemoglobin and he is not striving for several days. Do you give supplementation with sodium? The breast milk is without fortifier.
So if the baby is not growing, if you use that questionnaire that I showed you, then the baby needs to have some form of supplementation. And the forms of supplementation, I don't know if you have a breast milk fortifier available to you, but I think that to provide some form of fortification with more protein would be very helpful. Remember, human milk has relatively low quantities of protein, calcium, phosphorus, and zinc. And these babies, the very preterm babies, are growing extremely rapidly. At least they are programmed to triple their body weight in the first 3 months after birth, if a baby is born at 28 weeks gestation, for example. So that growth rate is faster than a term baby, and so that baby requires more protein, calcium, and phosphorus on a per kilogram basis than a preterm baby would. And so some form of supplementation would be probably very helpful for this baby. What is commonly done is, as I mentioned, the milk fortifiers are commonly used. There are fortifiers that are being developed that are of human source. I know that that's something that you probably would not want. We have not seen an increase in necrotizing enterocolitis with
excuse me, please.
Continuing to feed the babies if you are giving a blood transfusion. The evidence for discontinuation is extreme. A couple of papers.
You mean I'll add feed with, for example, a premature formula, or adding some form of like Similac Neosure or something to the breast milk itself, while this poses a question for the osmolarity?
About adding material to the breast milk.
Yeah.
And what is the...
like Similac Neosure, which is sometimes can be added to the breast milk, but this poses a question.
Yes.
Okay.
So what we do is we have available to us milk fortifiers that we can add to the breast milk. I don't know if you have those fortifiers available to you in Cairo. At least the last time I was there in Cairo and talking to my colleagues there, it sounded like you may not have those available to you. If the human milk fortifiers, as I mentioned, you know, that there's, you start with 1 packet of the human milk fortifier in 50 milliliters of human milk, and then you progress to 2 packets in 50 milliliters after, in order to get a greater protein concentration. That's what we do. If you do not have that available, one option is to take a preterm formula, to add some of the preterm formula to the human milk, you know, something like a half and half, or, you know, different proportion, or to give an occasional preterm formula feeding to those babies. that will add the amount of protein and minerals that that baby will be getting. Does that adequately answer that question?
Yeah, you answered. Dr. Iman. Another question, please, Professor Zhu.
Yes, hello. I want to ask you about the rapid catch-up growth for the IUGRs, because it is a major risk factor for metabolic syndrome, and we don't have a guideline, a true guideline for the accepted weight gain in the post-discharge period of the IUGR babies. So you said now that we can supplement or fortify the breast milk or add preterm formula if the baby is not having a proper catch-up growth. So at which percentile you advise introduction of preterm formula, and what is the accepted percentile curve weight gain to avoid the metabolic syndrome, and the final weight gain you recommend to stop adding a post-discharge formula or fortification of breast milk? Which percentile curves do you accept?
Is if we begin very aggressive feeding in a baby who is IUGR shortly after birth, you may actually induce a refeeding syndrome. Very similar to as if you have a malnourished or undernourished individual, somebody who's been starving for a couple of weeks, and then all of a sudden you give that person a very enriched diet. That person can become very sick. So for the short term, we have this concern in IUGR babies that we might actually be making them sick by pushing them too hard. And so I make that a little bit of an exception where I do not provide an immediate 4 grams per kilo per day of amino acids right after birth. I may be a little bit slower and monitor those babies closely in terms of their BUN, in terms of their phosphorus in the blood, to make sure that short term we are not causing problems. Long term, you bring up obesity and metabolic syndrome. Yes, those are concerns. And so I think that the best that we can do for those IUGR babies right now is not necessarily to work very hard to get them onto a growth curve that matches that with AGA babies, but to get them onto a growth curve that is their own growth curve that may parallel some of the standard growth curves. You would see some kind of catch-up growth in those babies, and that is a potentially good thing for their neurodevelopment. But I do not push those babies real hard in terms of aggressive feedings. I like to see them have their own growth curve that at the very least parallels the regular growth curves.
Okay, another question, please, from Dr. Julian Eason.
Hello, Joseph. Nice to hear from you today. Thank you for that. I have a question about, you showed some very nice pig data about how the pig intestine dramatically grows and increases when the milk is given and we are enteral feeding. My concern is the pig data on the premature piglet, that when the premature piglet is then exposed to artificial milk, that the gut becomes more leaky and the gap junctions become wider. And therefore my concern is with the trophic feeding, if you don't have breast milk. Because all these studies are telling us that breast milk is great and we want that. But some of us just don't have breast milk or availability of breast milk below 30 weeks. The question then, if you then look at the pig data of starting artificial milk on day 1, dramatically increasing inflammation, when should we start artificial milk if no human milk is present? Thanks.
I think that that's a question that has not yet been 100% answered, but I think that we have enough information now that suggests that not feeding is worse than some feeding. So in other words, putting some substrate in the gastrointestinal tract actually whether it be formula, whether it be human milk, actually will keep these tight junctions from being more highly permeable. So food in the gastrointestinal tract is important. So let me just provide you with a little bit of information that has to do with microbes in the gastrointestinal tract. Microbes will take carbohydrates and convert them to short-chain fatty acids. And whether it be carbohydrate that comes from human milk or whether it comes from formula, these microbes will convert some of the carbohydrate into the short-chain fatty acids. Now, one of the most important of these that relate to gut permeability is butyrate, short-chain fatty acid. And butyrate is very, very potent in terms of decreasing permeability. And there are cell culture studies and studies done in animals that show that a provision of carbohydrates and when there's microbes present will produce this butyrate and have this closing the junction response. Now, I like the idea of human milk whenever it's possible, but there are some mothers who have a C-section, who have diabetes, certain risk factors where they will not be able to provide their milk. I think the worst thing you can do for a baby like that is to not provide any enteral nutrition for 5, 6, 7 days after birth. So I would go ahead and provide some enteral nutrition, whether it be formula. We do use donor milk here. I know that that's not something that is being done in Cairo, but in our unit we use donor milk. But I think formula, some food is still better than no food at all in that situation, for the physiologic reasons that I mentioned.
Okay, I have a question about adding cereals or rice, oat to as a thickener for GERD. Hello? Professor Ju? Did you hear my question?
No, I'm sorry, I did not hear your question. Okay, maybe somebody can repeat that question.
I'm asking about adding cereals, rice or oat as a thickener to one way of treating gastroesophageal reflux disease.
You're asking, please correct me if I'm wrong here, you're asking about rice cereal?
Yeah, adding rice cereals or a rice-based formula or a oat to the breast milk as a thickener and calories in cases of gastroesophageal reflux.
Okay, so you are talking about adding rice cereal or a thickener for babies for gastroesophageal reflux.
Yeah.
Is that correct?
Yeah, correct.
Okay, so there are studies that suggest that thickening the feedings may actually decrease the amount of regurgitation that these babies have. But their actual gastroesophageal reflux is not changed with giving the rice cereal or the thickeners. So you can decrease the regurgitation or vomiting, but you will not decrease the gastroesophageal reflux. So for the most part, there are very few babies who will benefit from adding rice cereal or thickeners. And I do want to reiterate that at least that one incident that we have had with a thickener that was given primarily to babies who were having significant apnea and bradycardia, that was the Simply Thick thickener that ended up resulting in necrotizing enterocolitis. So I would use the thickening or the rice cereal sparingly. Rice cereal is a carbohydrate that has a lot of maltose in it, a lot of carbohydrate that is starch, that is not readily digested and absorbed by the preterm infant. The reason being is that the pancreas, excuse me, the pancreas of the preterm infant does not yet make adequate quantities of amylase, and it takes a couple of months for adequate amylase production. And so in terms of rice cereal being a substitute, a nutritional substitute, it is not very good as a nutritional substitute.
Okay. We'll take in one last question.
Hello. I would like to ask if you have a 28-weeker ventilated and still below the percentile, if you compare it on the curve, you are going to start to give him, can you high caloric formula or partially hydrolyzed or totally hydrolyzed formula, and you keep the TPN giving the calories?
Hello? Oh, you're back on now. I can hear you.
Professor Joy, did you hear the question?
Yes.
Okay, so you will answer, or you need to repeat the question again?
Hello, do you hear me?
I can hear you now, yes.
Yes. If you have a 28-weeker and he's still ventilated, still below the centile, and you want to increase the weight, what formula are you going to give? You are going to give high caloric formula, and you keep high caloric formula as a supplement, or you give a partially or fully hydrolyzed formula, and you give the calories by TPN?
Okay, so that's an interesting question. You have to be very careful with hydrolyzed formulas in preterm babies. And the reason why is because the hydrolyzed formulas frequently are not meant for preterm babies. They do, unless you have a very specialized hydrolyzed formula for preterm babies, you may not be giving adequate protein, you may not be giving adequate calcium and phosphorus. We do not use hydrolyzed formulas routinely for our preterm babies. And you mentioned the 28-weeker, we use primarily human milk, but if I did not have human milk available for a 28-weeker, I would use a preterm formula, one of the standard preterm formulas that is specifically made for preterm babies. So those formulas have more protein, they have more calcium, phosphorus, zinc, and the osmolality is generally less than 400 milliosmoles per kilogram of water.
Sorry, I want to ask a question regarding the use of suppositories for constipation in the preterm baby. You said that there is prolonged time for colon emptying. So how long can we wait, and when do we decide to do something about it?
So I wish I had a good answer for you. But we don't have a routine number of days that one could that I think will fit every single premature baby. The way I look at it is, if I have a preterm baby who is on full feedings, and if that preterm baby has been on full feedings for several days and is developing a distended abdomen, but still somewhat soft, what I recommend our nurses to do is to do some rectal stimulation with a thermometer, not to stick the thermometer into the baby's rectum, but just to do some stimulation to try to get the baby to poop with that. I do not routinely give glycerin suppositories or enemas. But there are some babies who might benefit occasionally from an enema, and so I would recommend something like a small, very gentle, warm saline enema, but I do not routinely give glycerin suppositories. A glycerin suppository has an osmolality of 12,000 milliosmoles per kilogram of water. And sometimes you actually cause damage to the babies, to these very small babies' rectum by putting in a glycerin suppository. So I pretty much stay away from them. But you know, if they seem to be working for you, I'm not going to argue that point. But I think that the evidence for the use of routine suppositories, routine enemas, is weak at best.
So if you hear good intestinal sounds, this is sufficient for you? You don't bother yourself about the frequency of stooling?
I rarely worry about it. If a baby is, let's say, is going for 5 days and the baby has been on full feedings and is starting to get a full abdomen, then I begin to be concerned. And I do occasionally give an enema to a baby like that. I will, first of all, recommend that the nurses do some gentle rectal stimulation, and almost all the time that works. But I rarely will give glycerin suppository in a baby like that. Very, very unusual. I think it's been years since I've given a glycerin suppository to a premature baby.
Okay, we thank you very much, Professor Neu. Actually, I cannot express my appreciation, and over the last maybe 2 months we had several emails to and fro, and actually you were very devoted to do with us 2 trials, 2 test trials on Friday and on Monday, just to ensure that our meeting will go through the program that you have used appropriately. Thank you very much. We are appreciating your effort, your time, your valuable time, and next conference next year, inshallah, you will be with us.
I hope so, inshallah. Thank you very much, and I want to apologize for not being able to be there personally.
Okay, thank you very much.
Thank you.